We're, is this on? Okay. We're going to go ahead and get started. This is our first grand rounds of the new year. I wanted to make a comment for those of you watching us on YouTube today. These grand rounds are being presented by a group of first-year students as part of their medical informatics course. What you're going to see this morning are a group of students who've been through the first part of courses in cardiology. Our first case is a cardio case. And the first part of their course in renal, where they've studied mostly the anatomy and physiology, but they haven't studied the clinical medicine yet. Much of that will come next year. So these exercises are about training students on how to be self-taught, how to work collaboratively as a group, how to present to a group, to learn something about the grand rounds format, to explore the latest research in this area, and to explore the medical treatment. They're also held to a first-year residence level or higher. And I think what you'll see today is very exemplary of that. So with that, let's go ahead and get started with our group who's going to present a case of a 52-year-old man with a cardiac arrest after an acute MI.
Good morning. Can you hear me? We are Group 13, presenting case 28, 2013, from the New England Journal of Medicine, a 52-year-old man with cardiac arrest after an acute myocardial infarction. These are the members of Group 13, and I am student Dr. Avery Joseph, presenting patient history and clinical presentation. Our case involves a 52-year-old man presenting to the emergency room with complaints of chest pain and pre-hospital electrocardiogram findings of ST segment elevation. The morning of admission, the patient was found to be in his regular health. At 8:30 a.m., he was found unresponsive in his home and EMS was called. He quickly regained consciousness and began complaining of chest pain and dizziness. He took 2 nitroglycerin sublingually. Upon EMS arrival, the patient was alert and oriented, although he did appear uncomfortable and was grasping his chest. He had a faint pulse, heart and respiratory rate were normal. He admitted to taking regular daily aspirin that morning. In the ambulance, he was placed on a cardiac monitor and found to be in sinus bradycardia without ectopy. He complained of nausea and vomited once and was placed on supplemental oxygen and 2 IVs were placed. He had a narrow pulse pressure of 110/90. His other vital signs were otherwise normal. He complained of chest pain of 7 out of 10 at this time. Our patient's pre-hospital electrocardiogram was unavailable. The following ECGs show findings similar to our patient's, including ST segment elevation in leads 2, 3, AVF, as well as leads V3 through V6, particularly noting the right-sided leads V4 and V5, as well as ST segment depression and T-wave inversion in leads AVL, V1, and V2. These findings are indicative of both left and right ventricular ischemia. En route to the hospital, the patient had a second episode of vomiting and became unresponsive. An IV bolus was started and tracheal intubation was attempted unsuccessfully. A nasopharyngeal airway was inserted. His past medical history included hypertension, dyslipidemia, and coronary artery disease with unstable angina. 12 years prior to this incident, he had a bare metal stent placed in his LAD. 5 years prior, he had reoccurrence of angina with a positive nuclear stress test, and 2 drug-eluting stents were placed in the left circumflex artery. His current medications were unknown, although he did admit to taking aspirin daily. His previous medications included atorvastatin, clopidogrel, and metoprolol. He had no known drug allergies. The patient was divorced and living with his girlfriend. He worked in construction and as a professional drummer. The family reported moderate alcohol consumption and former tobacco use. His family history included coronary artery disease. 30 minutes after being found unresponsive in his home, he arrived to the emergency room. While in triage, he was again alert and oriented with continued narrow pulse pressure of 110/90 and a regular heart rate. He then quickly declined, having a pulse of 36 and widening QRS complexes seen on cardiac monitor. External pacing was attempted without success. The patient continued to decline and experienced seizure-like activity and runs of ventricular tachycardia with wide ventricular complexes. He then went into ventricular fibrillation and CPR was started. The patient was intubated and amiodarone and lidocaine were administered. 9 direct current counter shocks were attempted without resolution of the ventricular fibrillation. Our patient's troponin was found to be negative. Troponin is the cardiac enzyme that becomes elevated in patients suffering from cardiac injury. Due to the acute nature of our patient's condition, his troponin had not yet become elevated. There was also subtle depression of both carbon dioxide and phosphorus, as well as mild elevation of glucose. His other labs were otherwise unremarkable. At this time, I would like to introduce student Dr. Alexander J. to discuss the patient diagnosis and management.
Hello, I am student Dr. Alex J., and I will be presenting the patient diagnosis and management. Although it was evident from the pre-hospital ECG that this was clearly a STEMI, if that were not to have been done, our patient presentation may have been due to multiple different etiologies, including stroke, pericarditis with cardiac tamponade, aortic aneurysm, or pulmonary embolism. The earliest change that is seen with the STEMI ECG is hyperacute or peak T waves, which represents localized hyperkalemia. However, this is infrequent and is typically not seen in the hospital setting. Over time, the ST segment elevation becomes more pronounced, and the ST segment may eventually become indistinguishable from the T wave. The QRST complex can also come to resemble a monophasic action potential. There are also subacute changes, which generally occur within the first 2 weeks, but may be present within the first few hours after the event. This includes a gradual return of the ST segment to the isoelectric baseline. The R wave amplitude becomes markedly reduced, the Q wave deepens, and the T wave becomes inverted. The ECG criteria for the diagnosis of MI includes new ST segment elevation at the J point in 2 contiguous leads with a cut point 0.1 millivolts in all leads other than V2 and V3. For leads V2 and V3, there is ST elevation greater than 0.2 millivolts, and there is also evidence of a new left bundle branch block, which indicates coronary occlusion and must be treated aggressively. Shortly upon arrival to the emergency department, our patient became unresponsive and was found to be in ventricular fibrillation. This arrhythmia is due to multiple foci firing rapidly, which does not allow the ventricle to fully depolarize. Instead, small parts of the ventricle depolarize each time, leading to an erratic twitching, which is an ineffective rhythm without any distinct waves. With ventricular fibrillation, which is a type of cardiac arrest, there is no effective cardiac output, so there is no effective circulation. It requires immediate defibrillation, and CPR is required to maintain circulation of oxygenated blood while in this arrhythmia. In our patient, VFib was sustained despite numerous defibrillation attempts because the cardiac myocytes could not maintain resting membrane potential due to the ischemia. In the emergency department, 2 concerns must be addressed with our patient. The first is the management of MI with ST segment elevation. With this, it is vital to begin administration of advanced cardiac life support, also known as ACLS. This consists of immediately beginning CPR and early defibrillation for treatable arrhythmias. This is to keep oxygen-rich blood flowing to the brain and other vital organs. The next concern is the ventricular fibrillation that continued despite 9 direct countercurrent shocks. The continuation of VFib indicates a possible occlusion, so our patient was rushed to the catheterization lab with CPR ongoing en route to determine the cause of arrest and attempt at reperfusion. STEMI management success depends on the speed of treatment and coronary revascularization. STEMI guidelines state that reperfusion should be achieved within 90 minutes of contact with the healthcare team, also known as the door-to-balloon time. The pre-hospital ECG was extremely valuable in this case to identify the possible issue and mobilize the entire catheterization team for rapid treatment. While waiting for catheterization, the following treatments can be initiated but should not result in delay, including a full-strength aspirin given by mouth, further antiplatelet therapy, anticoagulation therapy, beta blockers or nitrates, which are routinely used for the treatment of acute chest pain. However, nitrates dilate both arterial and venous vessels and are contraindicated with patients with suspected right ventricular infarction, which was the case with our patient. This is due to the decrease in venous return, compounded with the decreased contractility of the right ventricle, which can lead to severe hypotension. This potentially destabilized our patient and is what is believed to have led to his collapse in the emergency department. The shock refractory ventricular fibrillation indicates ischemia and infarction. An immediate coronary revascularization is required to restore blood flow. The options for this include IV thrombolysis and percutaneous coronary intervention. IV thrombolysis involves the administration of drugs to attempt to dissolve the clot to achieve reperfusion. This is less frequently used and must have no contraindications. However, many smaller hospitals do not have access to cardiology services, thus IV thrombolysis is still a viable option at an attempt for reperfusion. Percutaneous coronary intervention is shown to have better outcomes, including decreased mortality, decreased recurrent ischemia, and decreased major complications such as intracranial hemorrhage. The indications for revascularization therapy include a history of chest pain and at least one of the following: ST elevations greater than 1 millimeter in 2 contiguous leads, which our patient did have, a new left bundle branch block, or ECG evidence of isolated posterior wall infarction. Coronary angiography was performed, and an occlusion was found in the middle distal right coronary artery. A thrombectomy was performed, and a bare metal stent was placed to restore blood flow. CPR was briefly paused during this procedure, and an intra-aortic balloon was placed for hemodynamic support in case the patient's heart returned to an organized rhythm. Defibrillation was again attempted, and a brief episode of bradycardia was achieved, but ventricular fibrillation returned. A pacing wire was placed in the event that bradycardia returned again. In the image on the left, the single arrow is pointing to where the occlusion of the right coronary artery was at. On the right, the double arrow shows where the bare metal stent was placed, and beyond that, you can see that there has been increased blood flow. The single arrow up here indicates where the temporary pacing wire was placed, and the elliptical radiopacities that are seen in both images are just a ring on the finger of a hospital personnel that was performing CPR when the images were captured. The persistence of ventricular fibrillation indicated the possibility of another occlusion. Due to the patient's history of previous stents placed in the LAD artery and left circumflex artery, those sites were examined for potential occlusion. Angiography was performed during CPR that revealed acute occlusion in the mid-LAD, where the previous bare metal stent was placed. Angioplasty of the LAD was performed, resulting in 40% residual stenosis and restored coronary flow. VFib persisted even after resolution of the occlusion of the LAD, indicating the patient's heart may have been too distended to terminate VFib. Extracorporeal membrane oxygenation, also referred to as ECMO, was determined to be the next course of action for hemodynamic support to allow for resolution of VFib while maintaining perfusion. Data shows that early ECMO improves the rate of survival among patients with cardiogenic shock after STEMI. In our patient, the decision was made to initiate this treatment after 91 minutes of CPR and sustained VFib. In this procedure, blood is drained from the native vascular system, circulated outside the body by a mechanical pump, and passed through an oxygenator where hemoglobin is fully saturated with oxygen and carbon dioxide is removed. Blood is then heated to body temperature and returned to the patient's arterial circulation. Our patient was anticoagulated during this time. A 10th countershock was then administered, resulting in conversion to sinus bradycardia. Our temporary pacing wire was adjusted to a ventricular rate of 90 beats per minute. In addition, an anterograde perfusion line was placed down the ipsilateral superficial femoral artery to assist in perfusion and decrease the need for vasopressors. Our patient was supported on ECMO for 72 hours, and we began to see improvement into left ventricular function within 24 hours, and by the third day, his ejection fraction improved to 45%. To wean the patient from ECMO, flows were progressively reduced with additional anticoagulation under transesophageal echocardiographic guidance. A brief clamping trial proved that his ventricular recovery was adequate for decannulation and removal from ECMO. Now I would like to introduce student Dr. Sandy Jung, who will discuss the treatments, readmission, and additional considerations.
Hi, I'm student Dr. Sandy Jung, and I'll be talking about the treatments, readmission, and additional considerations for our case. While our patient was receiving ECMO, a neurological exam was performed on him. The patient was unresponsive to verbal or painful stimuli. He had no motor movements in his extremities and no brainstem reflexes. Therapeutic hypothermia was immediately administered on our patient for 24 hours. In therapeutic hypothermia, the body's core temperature is lowered to 32 to 36 degrees Celsius and maintained for 12 to 24 hours by either IV infusion of cold isotonic saline or cooling blankets. Hypothermia has been shown to improve neurologic outcomes in patients who are in a coma post-arrest. The lower temperature slows the body's metabolic needs and is a protective measure against any subsequent tissue injury. The therapeutic hypothermia was discontinued after 24 hours and the patient was gradually rewarmed. As the sedative wore off, the patient spontaneously opened his eyes and he was responsive to verbal and tactile stimuli. No neurologic deficits were found. During hospitalization, ischemia developed in his distal left foot and toes, most likely due to the aggressive use of vasopressor during his hospitalization. Gangrene was also found on all his toes and foot. Extracellular matrix was applied and the patient's foot healed sufficiently enough for him to resume his career as a professional drummer. The patient was discharged to a cardiac rehab facility 2.5 months after admission. The patient's positive outcome is likely due to his cardiac arrest being witnessed in the hospital. The patient was readmitted again for pancreatitis. The etiology for his pancreatitis is unknown. Congestive heart failure developed and a left ventricular thrombus was found. He was given warfarin and the left ventricular thrombus, congestive heart failure, and inflammatory symptoms of pancreatitis resolved in a month. The patient was readmitted a third time for congestive heart failure. A chemical stress test showed incomplete infarction in the anterior, anterolateral, and anteroseptal arteries. His right coronary artery had lesions flanking the stent, and the stent in the left anterior descending had severe restenosis. The patient underwent PCI of the right coronary artery and 3 drug-eluting stents were placed in the left anterior descending. The drug-eluting stent is mounted on a balloon catheter and placed in the artery. The balloon then inflates to expand the stent into the wall of the artery. The stent is coated with drugs that are locally released to stop activation and replication of smooth muscle cell proliferation. The major mechanism of the pathogenesis of instant restenosis is neointimal hyperplasia, which is the proliferation and migration of smooth muscle cells from the disrupted medial tissue of arterial wall into the intimal layer. After PCI and 3 drug-eluting stents were placed in the left anterior descending artery, congestive heart failure resolved. He has had no cardiac issues since this discharge. He continued to receive aggressive medical treatment for secondary prevention of coronary artery disease. The patient is a possible candidate for OMT after resolution of emergent symptoms. OMT can help improve this patient's lymph flow. Some ethical and legal issues in our case. During the first hospitalization, the patient's history revealed a bare metal stent in the left anterior descending and 2 drug-eluting stents in the left circumflex artery. The left anterior descending artery had severe restenosis, while the left circumflex artery was widely patent. Also, data shows that instant restenosis occurs in 1 in 5 with bare metal stents and 1 in 10 with drug-eluting stents. Knowing this patient's history and data, would the physicians have used all drug-eluting stents during his first hospitalization in retrospect? Could this have helped prevent any subsequent hospitalizations? There is an emerging study on if stents only help symptomatically, which raises the question of if the doctor should have chosen another course of action. He also received CPR for 91 minutes and ECMO treatment, which raises the issue of fair allocation of hospital resources. 91 minutes is a long amount of time to be receiving CPR. Also, ECMO is a resource-intensive intervention which requires a multidisciplinary team, expensive equipment, and an ICU bed. Chances of survival after ECMO treatment is higher in patients who do not have a history of chronic illness. This patient has a history of coronary artery disease and has received CPR for a prolonged amount of time. An ethical decision was made whether or not ECMO was the right treatment choice for this patient. Also, ECMO is not available in all hospitals, which raises the issue of equality of treatment amongst hospitals. The extensive resources available from this hospital helped our patient survive. We would like to thank these faculty members at this time.
Okay, so that was a great job and a great presentation. I know you guys, for the people watching, questions are written or submitted during the presentation that folks can answer, and I know you guys got some. So why don't we go ahead and get started with some of the questions the audience might have come up with.
Okay, I'm Stacy Ignowski, and one of the first questions we got, what are the causes of a narrow pulse pressure? And another question was, what is a narrow pulse pressure? So I'll just do both of those together. No, a narrow pulse pressure is going to be when you take your systolic minus your diastolic blood pressure, and then it's less than 25 millimeters of mercury difference. Different things that can cause this are significant tachycardia, early hypovolemic shock, pericarditis, pericardial effusion on tamponade, ascites, and aortic stenosis.
What is the root cause that's causing decreased pulse pressure in all of those scenarios?
Do you want me to answer it? Okay, so he asked, in any case of a narrow pulse pressure, what is the root cause of this? And that can be partially due to, from at least what I remember, a smaller difference in the pressure in systole versus diastole in the ventricles, which causes the, well, it would be either the tricuspid or bicuspid valve to close prematurely, and so not much blood is ejected.
Why is not what is that called?
Increased preload,
What is the amount of blood ejected called?
the ejection fraction, cardiac output. Sorry, everybody else. Oh,
Stroke volume?
stroke volume. Yes.
So in all those cases, decreased pulse pressure is a result of decreased stroke volume. Okay?
Yep. Decreased stroke volume is the answer.
What other questions do you have?
This question was, what are the physical signs of cardiac tamponade? There's a number of findings that may be present on physical examination depending on the severity and type, although none of them are highly sensitive or specific. We found that sinus tachycardia, even in the absence of frank hypotension, may indicate significant hemodynamic compromise. Elevated jugular venous pressure. The jugular venous pressure is almost always elevated in these cases and associated with venous distension in the forehead and the scalp. What's called pulsus paradoxus. This is defined as an abnormally large decrease in systolic blood pressure greater than 10 degrees or 10 millimeters mercury on inspiration, and it's common finding in moderate to severe cases and is the direct consequence of ventricular interdependence and a pericardial rub, which may be heard in patients due to the inflammatory pericarditis.
Okay, I got a question about when the troponin levels were drawn, and specifically in relation to if they were before or after the DC countershocks. And it's not clear exactly when they were drawn in the paper, although we do know that our patient did collapse and go into VFib kind of in the triage area right after he had arrived in the emergency department, so it can kind of be inferred that it was most likely after, because they probably were dealing with his VFib at that point. And I found a 2007 study that specifically looked at troponin T levels and how they can be affected by the DC countershocks, and it was hypothesized that they might cause kind of a false elevation due to possible damage from the countershocks on the heart, although this was not seen and not found. And the only thing that was seen to be increased was something called heart-type fatty acid binding protein.
Any other questions?
Okay, this next question is why ischemia leads to the depolarization of the membrane potential of cardiomyocytes. I found that severe and prolonged hypoxia can ultimately lead to cellular death and total loss of electrical activity, but we don't obviously see that in our case. So less severe hypoxia or of short duration will produce electrophysiological and mechanical changes in the heart. At the cellular level, the depolarization occurs by several mechanisms. Hypoxic conditions lead to diminished intracellular concentrations of ATP. The loss of this ATP leads to decreased activity of the ATP-dependent transport systems, including the sodium-potassium ATPase pump that normally transports potassium into the cell and it transports potassium into the cell and sodium out of the cell. Because this pump is electrogenic, it normally produces hyperpolarizing currents. The decreased activity therefore leads to depolarization because of the loss of this hyperpolarizing current. More importantly, the loss of the pump activity prevents potassium from being pumped back into the cell so that its extracellular concentration increases as its intracellular concentration falls, and this is ultimately causing the membrane depolarization.
Okay, so another question we had was what drugs are typically used in Okay, so the next question was what drugs are typically used in drug-eluting stents and why? The main purpose of the usage of drugs in drug-eluting stents is to inhibit in-stent restenosis from occurring, which can occur anytime we would put a stent in a patient's vessels. Therefore, the drugs that we use should be able to block smooth muscle cell activation and replication, which can occur locally at the site of injury. So the early generation DES stents mainly use sirolimus and paclitaxel, both of which prevent local proliferation of smooth muscle cell, while the new generation of DES use everolimus, which is an anti-proliferative drug, and also it has immunosuppressive actions, or also zotarilimus, which is an immunosuppressant. And the new generation stents are used more prominently now because they have a less occurrence of late stent thrombosis in patients.
All right, I'm going to answer two questions that are related. The first was what caused the patient's gangrene in his foot, and the gangrene was believed to be from recurrent bouts of heart failure and the aggressive use of vasopressors that led to hypoperfusion and caused the patient's gangrene. And what they did about it was they applied extracellular matrix, and that was the other question. What is extracellular matrix? It's a new type of therapy that involves applying an extracellular matrix scaffold consisting of a basement membrane with lamina propria that's originally derived from a porcine or pig urinary bladder. They remove the cells from the donor animal and prepare it and disinfect it, and then it's applied topically. It's available either as a sheet for partial or full thickness wounds or in a particulate form for deep tunneling wounds. And since the scaffold contains collagen, elastin, glycosaminoglycans, proteoglycans, and growth factors, they promote angiogenesis and enhance wound healing. And so far, it's been successfully used to treat surgical wounds, trauma wounds, chronic vascular ulcers, and diabetic ulcers with complete epithelialization of the wound and limited formation of scar tissue.
Hello. Excuse me. Sorry. So one of the questions we got was, what was the cause of the patient's bradycardia? If you recall, the patient first had a cardiac rhythm that was about 56 beats per minute. So our patient had a right ventricular MI, and that's also connected to the vagus nerve. So when this area becomes injured, it often causes a strong vagal stimulation, which will lead us to the sinus bradycardia, which we saw initially with EMS.
Easy enough. You guys did a great job. Congratulations. I have one quick question for all of you is, what do you think the take-home messages are from this case? You covered a lot of different categories, but what are probably some of the more important questions you want the other first years in here to take home from this case? And you said something I had written down, so I'm going to hand it to you first.
I think one of the take-home messages is the patient's persistent VFib was likely due to his nitrate use initially, although it's typically given excuse me, as part of the treatment. I think in this case it actually hurt him as well.
Something not really specifically medically related, but it's clear that in this case that teamwork was essential from EMS through the people in the emergency department. Just the care was handed over very effectively and efficiently, and I think that ultimately helped the patient survive.
So that 90 minutes from the door, or from the minute this started all the way up to the cath lab, was huge. Anything else you guys thought was important?
I think the ECG was probably the most important part of it because that's what initially diagnosed the STEMI, and then they could start rapid treatment for that. So I think that's what saved his life.
Okay. Anybody else? A couple other things that I marked down that you were presenting was utilization of therapeutic hypothermia. I think that had a very pronounced effort on his neurologic outcome after going through 91 minutes of CPR. And then the whole thing about bare metal stents versus drug-eluting stents. And I would guess that you guys would say during that first hospitalization when they were doing that first study, they probably should have replaced that bare metal with a DES at that time. Yeah, kind of my sense. Okay, great job. Congratulations. And let's give you a round of applause and get our next group up here. Okay, so our next case is about a 77-year-old man with leg edema, hematuria, and acute renal failure.
All right, so good morning. We are group 14. We'll be presenting case 20 from 2012, a 77-year-old man with leg edema, hematuria, and acute renal failure. These are the members of our group. And I am student Dr. Mary Carr, and I will be presenting the past medical history and clinical presentation. The chief complaint of our patient was that he was a 77-year-old man that presented with bilateral lower leg edema, as well as a red papular rash on his feet. Patient history: the patient had a past medical history of hypertension, atrial fibrillation, intermittent hemoptysis, aortic aneurysm, hepatic and renal cysts, and benign prostatic hypertrophy. His social history was that he had a 55-year PAC history. He occasionally had alcohol use, denied any type of drug use, and was a retired construction worker. Relevant family history was that his father died of an MI at 58 years old. 1 month prior to admission, he visited his primary care physician, where he presented with bilateral leg edema, a bilateral papular rash, and worsening hypertension. At this time, amlodipine that he was already on was discontinued. He was continued on his lisinopril, and he was started on diltiazem and atenolol. However, the atenolol shortly produced shortness of breath and wheezing, and he was quickly discontinued from that. 20 days prior to admission, he visited his cardiologist, where he presented still with bilateral leg edema and dyspnea. Physical exam showed a BP of 156/90, and his pulse was 70 and had an irregular rhythm. He had a +3 lower leg pitting edema. The diltiazem at this time was discontinued, and he was started on chlorthalidone. 15 days prior to admission, he followed up with his cardiologist. He did report an improvement in dyspnea. However, physical findings showed a 3.6 kilogram weight loss, which was quite unusual considering his leg edema. His BP was 146/80. His BUN level was at a 34 and creatinine at a 2.7, resulting in a BUN creatinine ratio of 13. The chlorthalidone and the lisinopril at this time were discontinued, and he was started on an aspirin regimen of 81 milligrams, taraxacin, and an oxycodone acetaminophen combination drug. 9 days prior to admission, the patient reported fever, shaking chills, occasional chest tightness, and a decrease in his dyspnea on exertion. 6 days prior to admission, he reported non-bilious emesis twice, hemoptysis once, and hematuria. 5 days prior to admission, the patient went to the emergency department of a different hospital, in which the physical findings showed a BP of 141/85, a pulse of 80, respiratory rate of 22, and his lungs had fine crackles at the base. He had a papular rash, and a CT showed an 8-centimeter asymptomatic abdominal aortic aneurysm. At that time, he was administered IV fluids and started on ceftriaxone, heparin, omeprazole, ferrous sulfate, nifedipine, and terazacin. His laboratory values 5 days prior to admission showed a decrease in his hematocrit and hemoglobin level and an increase in his urea nitrogen, glucose, and creatinine. His BUN creatinine ratio at this point was still 13. Urine analysis showed his urine to be brown and turbid with occult blood of 4+ and albumin of 3+. His sediment test showed the presence of red cells, white cells, red cell casts, squamous epithelial cells, bacteria, granular casts, and yeast. 1 day prior to admission, laboratory values showed still a decrease in hematocrit and hemoglobin levels, as well as an increase in urea nitrogen, glucose, and creatinine. At this point, his BUN creatinine ratio was a 22. At this point, a renal biopsy was done, the results of which we will be discussing later. The patient was admitted to Massachusetts General Hospital, where his physical findings showed a 135/85 BP, faint lung crackles bilaterally, and a 3+ lower leg pitting edema, and he still had a non-palpable blanching macular rash on both medial malleoli. Admission laboratory values showed still a decrease in hematocrit and hemoglobin and an increase in urea nitrogen and creatinine. His BUN creatinine ratio at this point was a 21. Urinalysis showed an improvement in his urine in that it became yellow and clear. However, occult blood was 3+, and his albumin was a 3+ as well. Sediment tests showed the presence of red cells, white cells, and granular casts. I'd like to introduce student Dr. Whitney Kelly.
Good morning. My name is student Dr. Whitney Kelly, and I will be presenting the differential diagnosis for our patient. All differential diagnoses for our patient fall under the overall diagnosis of rapidly progressive glomerulonephritis due to a rapid loss of kidney function, which is defined as less than 50% function in a time period of 3 months. Additionally, rapidly progressive glomerulonephritis is characterized by hemoptysis and glomerular injury as evidenced by our patient's hematuria and proteinuria. The hallmark pathologic conditions of this clinical presentation are red blood cell casts and crescent-shaped glomeruli, in which crescent formation occurs due to extracapillary proliferation of epithelial cells. Crescents are composed of proliferating glomerular epithelial cells and lymphocytes and occur following an inflammatory injury involving the capillary walls, such as immunoglobulin deposition. Plasma proteins can leak into the urinary space where exposure to procoagulants leads to fibrin deposition. Activation of coagulation factors such as thrombin is the suspected cause of crescent formation, although the exact mechanism has yet to be confirmed. If left untreated, crescent-shaped glomeruli can lead to advanced glomerular sclerosis, as indicated on the left, seen in our patient's renal biopsy, in comparison to a normal glomerulus on the right. Rapidly progressive glomerulonephritis is caused by 3 major categories of disease: anti-GBM disease, or anti-glomerular basement membrane disease, pauci-immune glomerulonephritis, and immune complex glomerulonephritis. Due to our patient's physical findings, anti-GBM diseases, specifically Goodpasture syndrome, was the first disease to be considered. Goodpasture syndrome is an autoimmune type 2 hypersensitivity where IgG binds to the non-collagenous domain, or NC1 domain, of the alpha-3 chain in type 4 collagen found in the alveolar and glomerular basement membranes. Goodpasture syndrome is typically associated with smokers and is more common in males. The significant clinical findings for Goodpasture syndrome is hemoptysis and red cell casts. Significant clinical laboratory findings include a positive c-ANCA as well as a positive anti-GBM antibody test. Our patient presented with several of the expected findings for a patient with Goodpasture syndrome, such as hematuria, hemoptysis, oliguria, and proteinuria. However, he had no indication of pulmonary hemorrhage. Furthermore, his c-ANCA and anti-GBM antibodies on ELISA testing were both negative, making a diagnosis of Goodpasture syndrome initially unlikely. When considering the category of pauci-immune glomerulonephritides, granulomatosis with polyangiitis, microscopic polyangiitis, and Churg-Strauss syndromes were the 3 diseases considered. Granulomatosis with polyangiitis is also known as Wegener's granulomatosis. Although our patient had some of the expected findings, he did not present with a vasculitic rash, eye disease, or any form of an upper respiratory tract or ear infection. Additionally, his c-ANCA was negative, making a diagnosis of granulomatosis with polyangiitis unlikely. As for microscopic polyangiitis, our patient had no indication of granulomatous inflammation, nasal or oral ulcers. Additionally, he had a negative p-ANCA test result, making a diagnosis of microscopic polyangiitis unlikely. The last pauci-immune glomerulonephritidae that was considered was Churg-Strauss syndrome. The only expected finding that our patient presented with was pulmonary infiltrates, whereas he did not have any form of eosinophilia or elevated IgE levels, which are characteristic findings in individuals with Churg-Strauss syndrome. Further, he did not have a positive p-ANCA test result, making a diagnosis of Churg-Strauss syndrome less likely and allowing us to consider the possibility of an immune complex glomerulonephritidity. Under the category of immune complex glomerulonephritides, there are 3 subcategories indicating normal complement levels. Systemic lupus erythematosus and post-streptococcal glomerulonephritis are both indicative of low C3 levels, whereas cryoglobulinemia is indicative of low C4 levels. IgA nephropathy and Henoch-Schönlein purpura are both indicative of normal complement levels. When considering the possibility of a diagnosis of systemic lupus erythematosus, our patient had renal involvement, but none of the other characteristic findings for a patient with systemic lupus erythematosus. Further, he had a negative anti-ANA antibody test result, making a diagnosis of systemic lupus erythematosus unlikely. When considering the possibility of a diagnosis of post-streptococcal glomerulonephritis, our patient did not have any history of a recent streptococcal infection, nor did he have low C3 levels or low CH50, making a diagnosis of post-streptococcal glomerulonephritis unlikely. For cryoglobulinemia, our patient did have hematuria, proteinuria, and gastrointestinal involvement, but he had no form of pulmonary hemorrhage, petechial rash, any history of hematologic disease, digital ischemia, or arthritis. This made a diagnosis of cryoglobulinemia unlikely. When considering a possible diagnosis of IgA nephropathy, our patient once again had no recent upper respiratory tract infection, no mesangial hypercellularity, and he did not have any IgA deposition on his mesangium. This made a diagnosis of IgA nephropathy less likely. Henoch-Schönlein purpura was the last immune complex glomerulonephritidity that was considered. Our patient, however, did not present with any palpable purpura, a recent upper respiratory tract infection or sepsis, and once again had no IgA deposition on his renal biopsy. This made a diagnosis of Henoch-Schönlein purpura unlikely. After initially dismissing a differential diagnosis of Goodpasture syndrome due to our patient's negative c-ANCA and anti-GBM antibody tests, the differential was reconsidered after reviewing our patient's renal biopsy. As seen on the screen, pathologic analysis of the glomerular basement membrane for our patient on our patient's renal biopsy revealed significant IgG deposition as visible in this IgG-specific immunofluorescence stain. For Goodpasture syndrome to be the correct diagnosis, the possibility of a false negative test result needs to be addressed. While a positive c-ANCA can be a good indicator of Goodpasture syndrome, it is not present in all patients. Therefore, while a negative c-ANCA is helpful, it is not necessarily a reliable test for effectively ruling out a possible diagnosis of Goodpasture syndrome. Anti-GBM testing is considered to be the proper standard of care for a suspected Goodpasture's case. This test has a sensitivity of 98%, leaving a 2% error rate in a false negative test result. Possible reasons behind a false negative test result include an anti-GBM target other than the NC1 non-collagenous domain of type 4 collagen, or an antibody with a high affinity for the NC1 domain that is circulated below the level of sensitivity for the ELISA testing capabilities. The latter was suspected in this case and confirmed via Western blot. Western blot analysis shows antibodies to the alpha-3 chain of type 4 collagen in this patient, as shown by the arrow, as well as the 2 arrowheads, which indicate control patients. The positive presence of anti-GBM antibodies led to a working diagnosis of Goodpasture syndrome in our patient. I would like to now present student Dr. Brian Kinney.
Good morning. My name is student Dr. Brian Kenny, and I will be presenting the treatment, emerging research, patient communication, and ethical considerations. The treatment for our patient's rapidly progressive glomerular nephritis consisted of glucocorticoids, cyclophosphamide, and plasmapheresis. Our patient also underwent another medical procedure consisting of an aortic aneurysm repair. Our patient was prescribed methylprednisolone, a glucocorticoid. Insulin was added on the 3rd day due to the systemic effects that glucocorticoids can cause of insulin resistance. Glucocorticoids have been empirically derived to slow down the progression of the rapidly progressive glomerulonephritis. The benefits for our patient are derived from the glucocorticoid's ability to activate the enzyme lipocortin. Lipocortin deactivates phospholipase A2. Phospholipase A2 is used to liberate arachidonic acid from the cellular membrane for the synthesis of prostaglandins and leukotrienes. These immunological molecules could exacerbate our patient's kidney disease. Our patient was prescribed cyclophosphamide, a alkylating drug that transverses the cellular membrane and its metabolites cross-link DNA. It interferes with rapidly proliferating cells and prevents the further synthesis of pathological antibodies. Our patient had plasmapheresis. Plasmapheresis is used in autoimmune diseases consisting of autoantibodies. The benefits for our patient are derived from the ability of plasmapheresis to remove substances with high molecular weight, such as anti-GBM antibodies. Plasmapheresis also removes pro-inflammatory molecules such as cytokines and coagulation factors. The OMM considerations for our patient were when our patient presented with leg edema, we could begin and end our treatment with opening of the thoracic inlet and using petrissage and effleurage techniques to help move the lymph back to the central core area 1. However, when doing these techniques, we would have to monitor our patient's status to make sure that we were not exacerbating our patient's condition. We would also evaluate the paraspinal tissues of T10 to L2 for tissue texture changes, asymmetries, restriction of motion, and tissue tenderness. We would evaluate these spinal levels because this is where the kidney sympathetic innervation originates. Although this treatment would not help our patient's kidney disease itself, it could help to help with the symptoms that our patient was feeling. Glucocorticoid, cyclophosphamide therapy was continued with the plasmapheresis until there was removal of all anti-GBM antibodies. Our patient then underwent the repair of his aortic aneurysm to lower chances of rupture. Our patient was discharged after the surgical recovery, and there was undetectable levels of anti-GBM antibodies in his serum. Our patient returned for a 2-week follow-up and received hemodialysis after progressive renal failure. Our patient returned 1 month later with the development of a perforated viscus, due likely to his age and complex medical condition. He decided that surgical repair was not in his goals of care, and the patient died soon thereafter. For the emerging research and alternatives, there's a new form of plasmapheresis called double filtration plasmapheresis. It allows the physician to selectively remove substances from the plasma. Therefore, you can remove less plasma from the patient, lowering the chances of potential side effects. Rituximab is commonly used in leukemia patients as it targets the CD20 identification marker on antibodies and works as an immunosuppressant. It has not been clinically responsive yet in rapidly progressive glomerulonephritis and would only be used as a last resort if the standard of glucocorticoids, cyclophosphamide, and plasmapheresis were not responding in the patient. Fostamatinib is in phase 2 of its clinical trials and has been shown to completely remove anti-GBM antibodies. However, it has not been tested in rapidly progressive glomerulonephritis. For the ethical and law considerations, our patient must have had the capacity to make the informed decision of choosing to not undergo surgery for his perforated viscus. The take-home points for this case is that a thorough workup is needed on all hypertensive patients, as well as addressing possible false negatives. A physician must perform a workup on all hypertensive patients to find a potential identifiable etiology, as this may result in a more appropriate diagnosis and treatment regimen. Although laboratory testing can be helpful, when dealing with complex cases such as our patient, the possibility of a false negative needs to be addressed, as diagnostic testing is not always definitive. We'd like to acknowledge the faculty. This is our bibliography, and we will take any questions.
Great job on a complex case. So who wants to start with some of the questions you got?
All right, so our first question was his anemia really iron deficient, requiring ferrous sulfate? If not, what was the cause? And also, what was the rationale for starting the ferrous sulfate? So the ferrous sulfate was administered initially because the patient had low hemoglobin levels. So it was believed he had an iron deficiency anemia. However, most commonly with chronic renal failure, a patient would be normocytic and normochromic, and it would rather be the EPO deficiency as the cause of the anemia.
Our second question was, what does the presence of red cell casts in urine indicate? So the presence of red cell casts in urine is always pathological and indicates usually the glomerular damage or glomerulonephritis, and the differential would be, as we discussed during our case. And the way it forms usually is the red cells, they leak through the basement membrane into the glomeruli, and they form a tubular structure in the distal convoluted tubule, and they get stuck there. And eventually, due to hypertension or other pressure, they can be passed down the urinary tract, and that's how they are formed and found in the urine. And the second question we got was, what is a major long-term bone marrow complication of alkylating agent use? So this question is about cyclophosphamide, and the two most common adverse events of cyclophosphamide are hemorrhagic cystitis, and we usually use mesna to treat that, and the second one is transitional cell carcinoma. Of the bladder.
Any other questions? We have a comment from our hematologist on use of Cytoxin, so why don't you come on down here and comment on that.
Thanks. So the question was, what's the most common bone marrow toxicity that can occur? While the statements that you make are true, there can be bladder toxicities. Most of them are acute and have to deal with delivery of chemotherapy into the bladder, and the metabolites of alkylating agents in the bladder is a compound known as acrolein, which causes contact irritation and hemorrhagic cystitis. The most common bone marrow complication, there's actually two of them. One's going to be myelodysplasia, which is a disease that typically affects older patients. The second is going to be acute leukemia. So these agents are leukemogenic, which is why we want to make sure that we're considering that in administration of these agents.
You guys have any more questions? Because we've got a couple more that were maybe emailed in or listed in. Here, I'll give you this mic.
We had a question on why the rash was first described as papular and then later described as macular, and did the appearance change, or was it always a maculopapular rash? Upon looking back at the case, it was initially described as papular whenever he was when he first went to see his primary physician. And then upon, I think, the actual admission to the first hospital, they described it as a non-papular macular rash. They talked to the patient, and he said that when he first was having problems with the rash, he could feel it, and it was palpable. But then whenever he went to the hospital, it was non-palpable. So it's not understood why it changed, but it does seem that there was actually one type of rash initially, and it possibly would have changed along the course of his treatment.
Another question that we got was, what are some of the possible causes of leg edema? And leg edema being an abnormal accumulation of fluid within the tissues due to the body retaining salt and then next water. So some of the things that could cause that would be acute kidney failure, chronic kidney disease, venous insufficiency are some of the most common ones. And then there was also some NSAIDs and calcium channel blocker drugs could result in edema in certain patients as well.
Okay, so one of the questions was, what is the mechanism of action that caused the patient to lose weight given his leg edema? There was a 3.6 kilogram weight loss with edema due to the administration of chlorthalidone, a thiazide diuretic. Chlorthalidone increases the excretion of sodium, chloride, and water by inhibiting sodium ion transport across the renal tubular epithelium. Its primary site of action is the cortical diluting segment of the ascending limb of the loop of Henle. So although the patient maintained pooling in his lower extremity, fluid loss occurred in other body compartments due to the thiazide diuretic.
Another question we received was briefly explain ELISA and how it works. It stands for Enzyme-Linked Immunosorbent Assay, which is a common laboratory technique used to measure the concentration of usually antibodies or antigens in a solution. And usually an antigen must be immobilized to a solid surface and then complexed with an antibody that is linked to an enzyme. And detection is usually accomplished by assessing the conjugated enzyme activity via incubation with a substrate to produce a measurable product.
Is that it, or any other questions?
We had one more question of what is a perforated viscus? And the most common perforated viscus is a peptic ulcer, but it's really any lesion upon an organ that causes the internal tissues to be exposed to the external.
You're kind of saying it causes it to rupture,
yes,
right? Okay.
Yeah. And what we believe would be the cause in our patient would be trauma or injury, which the trauma would be the different surgeries that he had as well as his age really help. Yeah, is a compounding factor of it. So.
Okay, good job, guys. It was very good. I just a couple of things that you touched on. One is you got pimped a little bit. That's cool. Giving you a taste of third year, so for both groups. So that's kind of a good thing. Get you some early practice. You did a good job with it. You touched on C-ANCA, P-ANCA, anti-glomerular best membranes, ANAs, kind of like a quick review of immunology. Those are all good things that you'll be talking about a lot next year. So those are kind of good take-home points because they'll help you with the diagnosis of a lot of diseases. In fact, I'm going to talk to Dr. McCormick. Maybe what we'll do is send out to the class a list of diseases that those are characteristic of in terms of positive findings. So glad you brought it up. Great job. And again, you were clearly at a very high level. So congratulations. That concludes it. Thank you.